Our session today will be facilitated by Dr. Fazila Alauddin. She is a good chef, and she is among the original founders of AHIN, and she is the Senior Deputy Director of Planning Division of the Ministry of Health for the longest time. So please welcome Dr. Fazila. Okay.
Very good morning. I hope everyone had a good breakfast and a good sleep last night after all the dance. So today we are back into our deep dive session, and it will be on architecture. And so I'm just going through a quick one on some slides before we go in deep dive into the topic. So architecture, this was presented to the group AHIN members some time ago, where ICT in healthcare needs a clear blueprint so all stakeholders in a country will know how they can contribute to the structure as a whole rather than silos. So that is what architecture was. And actually, when we are talking about architecture, there are many times we keep on mentioning the word enterprise architecture and so forth. So actually, it's a shared blueprint and roadmap so that all stakeholders can understand about it. So this is what AHIN is recommending, to have a designated enterprise architect in the Ministry of Health to oversee this blueprint. But again, I have mentioned you don't have to have everyone certified. You just have to have that one and two main person to be certified and lead this whole thing. All right. Number two is engaging experienced professional and certified enterprise architects to advise government in the development of on the blueprint formulation. I think in many countries you may have this group of expertise, either it's in-house or it is from external parties. And we also will encourage the REACH community for knowledge sharing. So that is for architecture. So what is an EA? Just a bit on EA. There are many definitions on EA, but what's important is why we need EA. And actually, EA is actually a blueprint. So again and again, many people have debated this thing. Do we use the word enterprise architecture? People are very scared, especially when you want to have a buy-in from your top management, or you want to have a buy-in from your political masters. The word enterprise architecture is very scary. So maybe you can use better words when you are talking to them. For example, you can say it's a blueprint, or it's a business and technology strategy, that kind of word. So in a nutshell, EA is just aligning business to technology and not the other way around. Again, EA is aligning business to technology. And it's also will strengthen more collaborations among agencies. But a lot of challenges many countries have, so maybe today we can hear some of it from all of you, is lack of EA skills and competency, a lack of EA knowledge and leadership among senior management. Again, when we talk to senior management, my advice is do not use the word EA because it's a very scary word, all right? And it's also a gray area between ICT and business. So you really need to drive the need for a strategy or a blueprint. And again, I always mention this to everyone for the last 30 years. ICT is not about technology. People, you may not agree with me, but ICT is about business transformation. That is what ICT is all about. All right? So basically, we already gone through this yesterday. Many of you participated when we had the roundtable this year in September, and these were some of the best practices and main challenges. But today, I would like to listen from some of the countries or all the countries that are represented here and also online, if you can put in the chat. These are some of the questions, and once we get this feedback, we will consolidate this and come up with our findings for the workshop. Okay, so these are the questions I would like before I go to and ask everyone. What do you think is the value when we're talking about enterprise architecture? We also focus on interoperability. So, and I know the world is moving towards interoperability. The world is moving towards coordination, and the world is also moving towards public and private integration. So, what is the value of interoperability in your mind? And what are the examples of interoperability in your own country? If you can give one or two examples, very brief one. And what you think are the principles that interoperability was successful in your country? And what is your biggest issue? So now I open this to the floor. Who would like to volunteer first before I call country by country? To answer, just to give a brief description about these four aspects of architecture. All right, Pak Anis. Pak Anis, because you volunteer, we'll give you a prize later.
Yeah, okay. Thank you, Dr. Fazila. Interoperability in our context in Indonesia is a method or a way where a different people, group, or organization finally could talk each other. But in the context of the health situation, we are talking about talking each other on the aspect of health services. On this aspect, I would like to share that on the health services, currently we already implemented many application, many technologies. And given that the application or technologies developed by many partners, sometimes the system are not talking each other. So I would like to share about two cases in Indonesia. The first cases of the interoperability is where the health insurance trying to implement it. We call I think it's also interesting to talk about the term. Even the term interoperability is also scary in Indonesia. Sometimes the people talking interoperability also not easy. So they try to use other term. They use bridging because bridging is bridge is easier. It's also a way to bridge from one island to another island. You know, in Indonesia we have 17 island. The most important is to bridge between island to island. But interoperability sometimes is also not easy to understand.
So in that sense, just a quick one. So in that sense, we have many scary terms in IT.
Yeah.
So, and that is the mistake we make when we speak to our senior management. We like to use the jargon,
Yeah.
right?
Yeah.
IT jargon.
Yeah.
So yeah, okay, go ahead. Sorry.
Yeah. So in this context of health insurance, when they try to communicate with many hospital information system, because we have already the national ID, but in the hospital information systems, many hospital, we have 3,000 hospital. Every hospital use their own information system and use their own standard to enter the national ID. So interoperability is coming when the Ministry of Home Affairs provide this national ID, and then this national ID adopted by the BPJS or health insurance to use this national ID as identifier, and then they develop a method in which the hospital and also the health insurance could use this national ID to ensure the eligibility of the member of health insurance. So they have the web services application, and it will make easier the hospital to admit the patient. Formerly, there was two counter for the patient, the counter of hospital admission, the counter of BPJS. With the bridging system, there is only one counter, and it will be easier for appointment, and also appointment could be conducted at home. So formerly, even the admission from to the hospital could be started early in the morning. Even patient could put a helmet or anything before the counter open. There are long queue, but right now the system could be started earlier at home using mobile. Okay. So this is the first case of interoperability in the health insurance. The second one is for the vertical program. We have a TB national program. in TB, we understood that we use the very vertical recommendation from the WHO. All systems are implemented in many countries using the same standard data from the WHO. But in the hospital and also in the primary care, currently at the time we have two development partner implemented the different system. For the hospital, we use the ETB manager from the management of science cells, and also for the primary care, we use the local vendor. So the system for the TB actually very hard to combine the data from the hospital and also the primary care. Formerly, the data mostly are only supported by primary care. So started in 2015, the Ministry of Health finally to develop the interoperability using the web services as well, and the system for the TB already currently on only one, so that in the hospital, the data for all patient TB that are already diagnosed and then could be combined into the national system. Formerly, the staff in the hospital, they should enter twice to report to the national system. So interoperability in the aspect means that it will bring easier for the hospital staff to report actually one TB patient, but formerly with two systems, currently with only one. Thank you.
Great, thanks, Indonesia for that this one. That's so we heard about two use case, but before I go to any someone here, I would like to also talk about what is written in the chat. Some says, for example, Ka Hong Lam mentioned value. Value is a value over effort saving. It reduces the efforts of redundancy inputs. So that is the value what interoperability brings. And there's a very interesting question. Maybe Alvin, you can think about this question. From Sundar Ramanathan, what is the problem interoperability can solve, and what's its purpose? So that is one question to think about. And then we have from Francis Ooi, value of interoperability in health. When data can go to the decision maker fast, lives can be saved. So if we put patient and person in the center of everything that we design in our architecture, I think that's where the value is. And lastly, from Ka Hong Lam again, the issues, lack of common expertise, which we said has been one of the many issues, and also detailed and aligned understanding of interoperability itself by all stakeholders. Thank you for those online who has given this feedback. So perhaps, Alvin, why do we need interoperability? Yeah.
Thank you. So I think it's because the patients, in reality, as patients, and we become patients ourselves, we transfer across facilities. You know, sometimes we go to the clinic, sometimes we get admitted to the hospital, knock on wood. And without interoperability, our data gets stuck in those facilities. And because there's no interoperability. So one reason for interoperability is because we want to serve the information needs of our patients, that they are able to bring their records and their data across facilities. In the same way, if there's already a CT scan performed in the facility yesterday, why repeat the CT scan today if we can just get the results and the images from the previous facility? But that requires interoperability. That requires hospital A and hospital B, the hospital A yesterday and hospital B today, to agree to share that data in a format that hospital A and hospital B can understand. It seems like it's an easy thing to say, but in terms of the politics and the technology, there's some challenges with doing it. And the enterprise architecture approach is a good way to solve that problem. The business of serving the patient's need so that they don't need to shell out money again to repeat a test that was just performed yesterday, and the data, which are the images, and the application, which might be different in hospital A, might be using a different system from hospital B. But if they're using a standard image format, then they would be able to pass the data back and forth, and they would be able to open the images. And of course, the technology. There's a lot of technology actually already available. We just need to govern and manage all of the interoperability requirements.
But again, Alvin, I think again the technology interoperability will not happen without human working together. So maybe we'll ask Philippines, our host, our co-host today, if anyone would like to volunteer to give one about your issues of interoperability in Philippines. Anyone? Philippines? Is Charity here? Or Jovi? Auli? Yuli? Philippines? After Philippines, we'll go to someone online. Come on, Philippines. Okay, I tell you what. Think who's going to volunteer? I'll go to. Is India online? Someone wants to say something? I was informed India is online. Yeah. Who's online? Manisha?
Hey, hello everyone.
Yeah, Manisha, go ahead.
Yeah, am I audible?
Yeah, we can hear you. You can speak louder.
Sure. May I try to kind of give some answers from India side on this question?
Yeah, a brief one. Yes.
Yes. So the first question I think I need not kind of indulge upon, because everybody knows the value of interoperability. And I think no one in the group would doubt that without interoperability, it's not possible to have the overall shared health record ecosystem to be possible. So I'll directly go on the question number 2. What is the value of interoperability in your country? India is very much involved when it comes to interoperability in the digital health, and the Ministry of Health itself has been very pioneered in terms of interoperability. Just not Ministry of IT, Ministry of Health itself is taking a lot of steps towards that. So to promote interoperability in India, essentially, the one of the major step was done is to notify the various standards that are involved. It's just not only the semantic and syntactic interoperability, even standards required for security, privacy, and the other aspects in terms of the requirements and the workflow are also being notified and should be adhered by the EHR systems in India. Apart from that, in India, we also have set up the National Resource Center for EHR standards. So this resource center provides all its services free of cost to everyone. So the idea is to kind of set up an ecosystem which is easy for every implementer to adopt standards. So all the tools, services provided by this resource center are free and open source. That helps every public as well as private vendor in the country to, as quick as possible adopt these standards. So that's the another initiatives taken. And I would say the example of interoperability, for instance, in the Ayushman Bharat Digital Mission in India, we have adopted FHIR as standard for data structure, and the SNOMED City, LOINC, and DICOM as the other overarching standards for terminology, coding, and medical imaging. And that's how it is being made. In terms of principle for interoperability initiative, uh, in India, it is being believed that to start with, we follow the minimal and minimalistic approach. So not to overburden all the implementers for use of complex and the large data elements and multiple standards. Rather than that, a very smaller set was being adopted for Ayushman Bharat Digital Mission, so that it is easier for everyone to adopt it. Also is to look at the all different scenarios. It's just not that from day one you have to adopt standard. look for the older system, historic data, and also support data exchange for these kind of systems also, which are already existing there. So that those are few principles those are being considered while implementing standards and interoperability in the Ayushman Bharat digital mission. Now coming on to the last question on the biggest issues, um, I think the biggest issues currently being faced, just a personal opinion, there might be the larger ones as well. That the onboarding of older massive systems to standards which are already established, and they have a large amount of data, they have a old pre-established setup, and it is very difficult for even for the system users to change, and the vendors also, because we do not have mandation of standard in India, we do not have incentives for standardization, just that there is a whole support and the ecosystem is provided. So there the adoption is, I guess, is a little slower, but some or the other time in future, I hope that we have all these systems onboarded, and since India has a green field, almost many implementers are onboarding, but I think that was the one challenge that is currently faced. Thank you so much.
Thank you, Manisha. It's interesting that you mentioned about some standards. I think architecture interoperability is very much related to standards, which Boon Chye will take us on the next deep dive. We have heard about FIRE, Nomad, ICD Link, and so forth, and DICOM. And also, you also mentioned about semantic and also synthetic interoperability. So maybe later I will also request Malaysia to speak on that. So perhaps I have two more comments online. Albert mentioned about interoperability allows us to create new solutions using a broader set of application and processes faster. And we had a comment from Sundar Ramanathan. A user experience, data, application, and technology requirements and implementation difference across various stakeholders organization, an evolution of IT system without any business contact and comprehensions to be some of the problems, including manual, semi-automatic, and automation maturity dimensions. We also have issues mentioned by Manisha about legacy systems adhering to standards when we are talking about interoperability. Great. Now, Jovi, would you like to just mention a bit on maybe some of their experience in Philippines, and then after Jovi, we'll go to Malaysia, and then we'll go to Nepal, if you have some things. So if you can just give brief description, you can address any of those problems, either the issues or what you think the success is, or what do you think is really needed to have interoperability?
Yeah, actually, based on the ongoing experience that we have on the interoperability, other than the technology aspects, is the change management. And of course, we would like to emphasize again the important role of leadership and governance. Even at the level of the developers and IT people, it seems so hard at first because it's simple, the current development that they have, and they will be shifting to something new. So the major challenge would be that one. So change management is a very important aspect, and one should have a definite concrete plan on how to address that.
Thank you. So we are going back to people issues. We are going back to governance issues. So at the end of the day, the GAPS is also connected. You cannot have one without the other. So that is why AHIN chose the GAPS gaps. So maybe Ahmad, if you want to say something about Malaysia.
Hello. Sorry if I may just turn the microphone, otherwise I feel like I'm just talking to my boss. So in Malaysia, actually, we started from a point of inequality where some facilities are very mature in terms of what they have, in place in terms of the IT system, and some hospitals are still operating using pen and paper. So yeah, unfortunately, digitalization can be a force for inequality, and this is the logic behind the Malaysian Health Data Warehouse, to provide a common ground for facilities with different levels of digital maturity to actually be able to contribute data to the national data set. So what we have now, actually, if you ask me, as a middle ranking civil servant in the health ministry, I can tell you with almost absolute certainty, with good quality data about our discharge rates between the different categories of illnesses, and based on different demographic parameters, because we collect data from the most granular level of patient visits, and this was done via implementing semantic interoperability, and this is something that we actually include in our legislation. Okay, but having said that, we realized that after several years of publishing our annual indicators, answering parliamentary questions with data from our data warehouse, supplying the data to our researchers, we constantly still had problems with timeliness, data timeliness, because the manual processes are still being the bottlenecks for us to be able to generate timely, high accuracy and complete data. And even though we have good data collection in the government sector, whereby government facilities actually they're in charge of more than 2/3 of the patient admissions, we're still struggling to actually get the private sector on board. And the most challenging part is that this is not seen at the point of care, because data warehousing is just it's just a copy of the transaction data for analytical purposes. It's useful to us in the ministry, but we also want to be able to ensure that there is continuity of care between the different points of care, as what Dr. Alvin mentioned. So and this is the reason why we embarked on a separate venture with our health information exchange, that is to provide a FHIR-based information exchange that will be able to actually exchange data from the various information systems that we have, and we have many, I can tell you that. And actually this will be shared through web-based portals. So the hospitals that are still operating on pen and paper will have basically a light EMR called the provider portal, and the management portal for us at the ministry to do our work, and also a patient portal that will probably be deployed through a mobile app for patients to actually access their own health records. And that is how we in the long run, that is our vision in ensuring that there is interoperability between the different information systems.
Thank you. So yeah, again, we have heard this from India, from Malaysia, minimalists, trying to gather what is really required. And then we heard from Jovi about change management and also how difficult it is. So it's also interrelated. And we have someone online who has raised their hand, Sam. Sam, would you like to talk, to say something? Sam online? Sam Matino? Sam, can you hear me?
Hello.
Yeah, go ahead.
Yes, can you hear me? Okay.
Yes, we can hear you.
Well, there are so many things that we can possibly do, but our challenge here in the Philippines is that the private sector already have their own solutions that they have been implementing through various healthcare facilities. The problem now is what kind of system we need at the national level to be able to execute it. And that has been a challenge for us since I can remember since 2010 until now, how to do the integration part. So I don't know with other countries, but with a population of about 100 million or more, I don't know how feasible it is to do to execute an exchange. I don't know the experience of other countries. Has there been any successful experience so far to do an exchange at the national level?
Thank you, Sam. Well, is there anyone who would like to? Yeah, Nepal.
Good morning. Yeah, this from the technical background, purely technical background. So working with the public health workers and clinician, the interoperability is in technically we understand as a API, application interface. So this is how application interface works. Is a very small code that connect to different applications. So now in this modern age, if the business applications are not interoperable with their other applications, they are not more exist. That's why now WhatsApp, how we can understand the WhatsApp and Viber, how they can exchange their information to each other. That is the one of the example of interoperability. So until and unless our business need is there, the interoperability automatically comes. The one of the big challenge in the hospital that I have seen in Nepal is they really don't want to share their data. That's the problem. One physician, one clinician, they don't want to share their data to other organizations. So that's why Nepal government have already decided that all the private sector or government sector, they have to send the aggregated data, whatever, even is the IPD or like as a in-patient record or outpatient record or disease, these all things that need to be sent to the DHIS too.
So it's in legislation.
Yeah, this is in the DHIS too.
Okay.
And we have got a health facility. The one of the most important is national ID is very important for keeping the interoperability between the public to public. Like as if I'm taking the, I'm checking my data in one hospital, and if I want to have that data to another hospital, if those hospitals are managed by two different organizations, to different management, and those hospitals are not agreed, they legally or whatever, they have got own their rights, so they don't want to exchange the data. But me as a customer, me as a client, I need my data. That's the legal perspective. I need my data. I want to share my data to another hospital. So that's why the first interoperability must have to be people, the organization to people. That is the one role. And is my understanding internationally, I have not seen, even in, I think it is happened in Taiwan. The Taiwan, they are exchanging almost their data. But even in Japan, even in US, there is no one, clear case about the interoperability. In India, they have got the Apollo Hospital is exchanging their own data inside their network, but they are not exchanging to others. So this is the business issue.
Okay.
This is the business issue. That's why. The second thing is Nepal have already adopted the interoperability. We don't have interoperability lab, and we are now going to planning. And AHIN is going to supporting for that. GIZ is going to financially supporting to us. So we are going to establishing the objective of that lab will be invite all the private sectors and let them understand about the what sort of data set government needs and what sort of data they want to exchange. So that is the part. And mostly the challenges in Nepal is only the private old that our from India, the friend from India, what the legacy systems. This big challenge is we need to support those organizations who have used the old system. We need to support either financially or some sort of way by giving the incentive. We need to support them to develop their data set to convert. So that's why they can send it. And we feel during the COVID, we made interoperable almost for 65 different silos applications during the COVID. So all the labs, COVID labs, all the hospitals, they are now, even they are exchanging the line listing data. It's not only aggregated. They are exchanging the line listing data from one hospital to another hospital because they have already tested, the client have already tested COVID 1 week ago in one lab, and soon after he or she need to travel. then that information need to be given to the government. So that's why we have done that one by using the Tom API, though we have not used the interoperability lab. That's
Thank you. So I think that will answer Sam's question. What do we need at the national level? Actually, the technology is ready, but the people are not. The people are not ready to share. So again, if you put your person and the patient as a center, you will. So that is why I think you're right. It must come from the people. Maybe the people must say, I want this. I want, when I go from one hospital to one other hospital, you do not ask me any more questions, or you do not ask me to repeat tests. So when there is a need from bottom up, I think that will happen. So before we go to, just 1 minute, before we go to India, there are two more, no? Oh, okay. Before we, I would like to also mention what's mentioned online, yeah, by Victoria Casanova. India cited a critical success factor to interoperability, ease of adoption, no matter how sophisticated, advanced the architecture or interoperability is. If it is too complex, adoption will be challenging and slow. So the principle is make it easy, simple, and we need to keep it simple, useful, and usable. And another comment from Romulo Di Castro: when standards for interoperability are set up, healthcare facility adopters will have different levels of difficulties to integrate. I suggest there should be proportionate levels of support that national agencies provide to each independent healthcare facility to make the implementation of interoperability equitable. So again, back to governance and people. Well, now I think, yes. Yeah.
Just add to the last point, and then I think that relates to India. Like India's, like Manisha spoke about the National Electronic Health Record Resource Center. That is meant to be mandated by the Ministry of Health to actually support the community to adopt standards, and then how we can implement those standards into the applications.
Yeah.
There is a question actually from Dr. Chansali from Lao PDR.
Yeah. Dr. Chansley, can you come to the mic? And before that, it's also very sad that when you have to have legislation to make people talk to each other. You know, you have to regulate people. So when is it that we will not regulate people and people want it? So that is another thing. Yes, Dr. Chansley.
Thank you, Fasila. I just would like to share that whether I understand the meaning of interoperability or not, because
A bit louder.
in Lao we also have we have DSS2 as the main platform for the information system in Lao, but we try to link with other system like a human resource system and also the insurance, finance. So we successfully only linking with the we call M supply system, meaning logistic. So we logistic, they also have M supply different software, but we try to push the data from that for example family planning community or EPI community to push into the DSS2 so that we can compare between the service and also the drug and equipment, so we can see what is different. So our main issue is how we can integrate with the hospital information. Currently, hospital information have different software. So now we are trying to push the data from the hospital information into the main platform. This is so because the worker working in the hospital, they are enter the data into multi system, but they have to workload. So how we can reduce this? I think interoperability, talking about the value is very valuable, but how we can implement it in such a way that will be working. I totally agree with that. We're talking about interoperability, meaning we have to the same API, meaning that the same language, the same IT technique, they can work together. Thank you.
Right. Thank you. Yes, Dr. Bunchai.
Dr. Fazila, I seem like I I was still the session because of you talking about the interoperabilities. That is just a joke. Because my session is standard and interoperability, architecture standard interoperability is a hand and glove.
Yeah.
We have to talk.
It's handy.
I just to ask the group about the one of the issue that we like. Our friend from Nepal said that people don't want to share, right? Especially providers. Another issue after that is the architecture. Do we have a centralized architectures or should we have a federal architecture of that? And how that kind of the blueprint implemented? You know what I mean? I expect that we are going to discuss about this kind of the different architectures. I don't know. In Thailand, this is a very big debate on that because of nature of the provider. They don't want to share. And even in the US, they try to implement the interoperability for 10 years and have an incentive to give the money to the provider to implement standardized EMR. They are failed. And just recently, they have to enact another law called the Information Blocking Act, which will punish the hospital and the vendor if they do something that can prove that they are blocking the information that the people need. So it's not the simple thing. So my comment is to one question about the federal and central architecture. Another thing is just the comment about this different difficult thing about the interoperability and architecture. Thank you.
Bunchai, sorry, I took some of your time. No, because you cannot separate architecture and.
I was going to tell him he has his own session.
Yeah. Sorry.
No. What I mean
Yeah,
is that it's a hand and glove.
Yeah.
But the top,
Yeah.
what I raised is about the blueprint or architecture
Yeah.
in terms of those.
Okay. So it's a very interesting question about whether it should be at national, a central, or a federated kind of architecture. But again, back to architecture. Architecture is all about business. Business need, exactly like mentioned by our colleague from Nepal. The technology is there. The technology is available. But what is it that we need? That is why we need an architecture. So I have CP and then Elvin. Yeah, quick one.
Okay, thank you. I think what we understand, I think what you say is very important, actually, is the people, I think. But we also need to know the changes we're going through. I think in this community here, we have two extremes. One actually is the underdeveloped, where a lot of projects are centrally driven. So interoperability may not be actually that crucial. But once you reach Malaysia's level, we are in the middle grade, where the private sector start coming in. I think, and that's where the interoperability becomes quite important. So as we go up the journey from the underdeveloped, I think, into the sort of developing and hopefully develop at some time, I think the interoperability sort of network, the blueprint becomes quite crucial. If we set it at early stage, so the newcomer come in, they are more amendable to adhere to the system. So I think that's where I think that we should, I think for those member countries that are just embarking on this digital journey, to have that interoperability sort of framework, the blueprint in place, so that any newcomer, any business coming in should actually then conform.
that's
I think
good.
I think that's
So
one
that
thing.
means do the architecture early
Exactly.
and have a buy-in towards. But I'm sure every country is moving towards interoperability. So at the end of the day, the architecture will actually is for
So
interoperability.
as early as possible, I
okay.
think that's quite important. Second thing actually is the mindset of the people. I think I must say, but I think if I step on any toe, please forgive me. But we have two people here. One is actually the public servant. Public servant, and then one is the business people. Public servant, by and large, use the public fund to implement. They don't care where the money comes from, they spend it. So they have that kind of mentality, but they have the power of legislation.
Yeah.
And with that comes the arrogance, unfortunately.
Oh.
On the other, yes, I think so. Please, I think you see my foot, I have injured foot because I step on too many, right? On the other hand, the business people, they have to make money. And we have to understand that. These two groups have to understand each other. I think, and it's a convergent. The technology is there, I think, but we just need to converge that. So I think that if I can ask and I appeal to the public servant to step down and actually the business people to step down also to a level they can talk. I think that actually works well.
So from a love-hate relationship to a love-love
Love.
relationship.
And that's
Yes, Alvin.
that's the environment that AHIN wants to propose. That, let's talk about this, because I don't think government can do it alone. I don't think private sector can do it alone. I don't even think government with private sector working together will make it work. But they have better chances compared to working separately. So I have just two things. Sorry. Enterprise architecture actually has three parts: the current state architecture, the target state architecture, and the sequence plan. So you have to have that. That's the reason you have a blueprint, so that you have a guide from where you are right now to where you want to go. And really, the challenge is there's none. There is no target architecture, there is no current state architecture, and there is no roadmap. And we need to have that. So that's why we recommend you hire a professional certified enterprise architect. They have the skills and knowledge on how to help you come up with those architecture. Now, the current state will be different. The rural health unit in the village, in the island, will have a different current state from a hospital in global city. So you need to be conscious that as you are creating this roadmap, this is a roadmap specific from current state to target state. The target state is the same for everyone, but the current state will be different. I have an embarrassing story. We had a datathon last August 18 because the CLAB, the interoperability lab, we followed the WHO SMART guidelines, the policy, which is the narrative, we converted them into online forms together with the consultation with the clinical experts and public health experts and viral hepatitis program experts. And then we created the FHIR profile. I was telling this story to Dr. Rath. Once we created the FHIR profile, the next thing is you have to invite the EMR developers so that they will use the API, like what Raj mentioned. And basically, the EMR developers ask me, why do we need to do that for you, Dr. Marcelo? Who are you to tell us that we should use the API? And I think that's the block that we're going to hit. If there's technology, but there's the political part of the technology that needs to be in place. And I think unless DOH or PhilHealth will say, yeah, that FHIR profile, we should use that for viral hepatitis, nothing will happen. We will have a preponderance of FHIR profiles all over the world, but none adopted by government. It's not going to be a useful API.
That's very interesting. I hope Bunchai in the next will talk about adoption of standards. Before I go to Merrick, is about actually it's the COVID that actually has brought people together and knowing what's the importance of data and architecture. And for architecture, it's very important to have the as is and to be. So that's what the architecture is all about. It's about the business strategy. So I think I really hope everyone will do this architecture part before you even embark into systems or buying solutions. Yes, Merrick, you have something to say?
Yeah, I was just going to build off of what Alvin was saying, but emphasize the point of you need a compliance function within the ministries to make sure that those FHIR profiles are adopted. You need the expectations, whether it's policy or whether you can actually have regulation, but then you need that compliance function. And that's something we've struggled with in the United States quite a bit. We have the Office of the National Coordinator in our Ministry of Health that sets the standards guidelines. We have the regulations that create the structure that finds hospitals that do not implement systems that adhere to those standards. But then you actually need to check and comply and fine them. And it depends on the politics of the moment and the willingness and the staff to actually follow through with that. So under different administrations, we've had different amounts of success with the adoption of those standards. And currently, there's a big push for it. So currently, all the EMR providers and the hospitals are working to provide the minimal data sets that they're required to in a standardized format, which is FHIR, up to the CDC. However, under other administrations, that compliance function went away, and then the incentives for the hospitals to adopt, and then thus the EMR providers to provide the standards-based approach went away as well. So I think thinking about that as like an ecosystem of yes, you need you need to get the fire profiles developed. You need to create those kind of things. We also need to think through what is the compliance function to get at the point that Alvin was saying of like, who are you to tell me I need to build my forms in this way?
Thank you. Yes. Okay, I have two. A quick one, both. Bunchai.
I have a quick one because of it follow Alvin and Merrick comments. Uh, uh, over the year, I found that three things about the standard and interoperability and architecture have to do together. One, the business or clinical care model. Another one is the reimbursement system. And the third one is the standard and interoperability. These three things you cannot decide separately.
Yeah.
You have to come together and decide together. Then you will have incentive for the people to comply to the compliant to the services, and at the same time the information system people are designing the standard to seamless continuity of care, get the interoperable system for them at least at the minimum. So finger crossed, I will use this principle in Thailand in the next 5-6 years for the primary care. I don't quite sure that we are going to success or not, but now we gathering people who are the champion of the primary care services and the champion of the reimbursement and me together to design this system. Thank you. I will elaborate more if you want to know.
In fact, I think the success of Taiwan is actually the three principles. Buncha, if you agree to me, Taiwan is successful because of that three principles. Yes, go ahead.
Yes, good morning. I would just like to add context to the embarrassing story of Doc Alvin, because WA is one of the EMRs that they actually invited, and we were excited to participate, mainly because of the prospect of doing the first fire for the viral hepatitis program, and there was a little financial incentive. So thank you for that, Doc Eloy. But unfortunately, as we were discussing 2 nights ago, it seems that the incentives as well as the work that we're going to put in is really not enough, mainly because even if we do the work for free in behalf of our, let's say in our case, 200 LGUs, we found out in the same meeting or hackathon that the Department of Health is actually introducing a separate system, and that is going to be mandated to be used by the clinics where our system is also deployed. So, and then we are talking about digital health that is supposed to change the way we do things and deliver services.
Yeah.
So even if we do the fire, it will not be used by our clinics, and even if we get the incentive before the end of October, ba, Doc Eloy, so that we can get the incentive. I forgot the deadline, but it was a good proposal and supposed to be good partnership. But even if we do it, there's nothing really concrete that will be done, or our system will not be able to interoperate with the DOH system in the first place. Thank
That's
you.
a very interesting point. Actually, he's also talking about competition. But maybe government should decide whether you want to focus on integration or you want to focus on implementing HRS system and compete with the industry. So that is another thing to think about. So what is it that government wants to do? So, or at the national level, you know? So these are some of the things. Yes, you have something to say. Yeah, go ahead.
Yes, good morning, everyone. I'm Jonathan Cabrera from the EOS program. So,
Can
in
you
connection,
remove your mask? We cannot hear you.
in connection to what Sir mentioned earlier regarding the mandating of the use of a government electronic medical record system, actually, we don't mandate the use of it as long as the system, or the electronic medical record system, especially those developed by the private sector, they can still utilize those systems as long as they are conforming to and pass to the standards conformance interoperability validation of the government.
Oh, okay. That's another point for Philippines to take into account. All right. Okay. So I think I'm running out of time. I just want to show you one slide. This was shared with me. Thanks to Francis. I think he's online. This was this paper was done in 2006 by Ross and group, which talks about enterprise architecture as strategy, creating a foundation for business execution. So maybe you can also use this when we're talking about architecture, we are talking about integration. We cannot run away from standards. So what is the level of standardization do you want? And what is the level of integration do you want? And where we are in the box? Sorry, that is not diversify, is diversified. So many of our hospital systems are here with low level of integration and low level of standardization. But again, do you need to integrate and standardize everything? So that is one question. So maybe you want to move up to coordinate. So coordinate, perhaps you want to just you want to have integration, but your standardization is very minimal. You know, perhaps you want to share discharge summary so that you can have continuity of care or care coordination. But at the same time, you may want to have something that's high integration and high standardization. For example, your systems like your ERP systems, your finance, your human resource in hospitals, where it's all highly integrated and standardized. So that is another way of looking at things. Replicate is usually high level of standardization, but not integration. For example, systems out there for fast food, for example, for McDonald's, they may have a system, but not all the McDonald's outlets are integrated, but they are all highly standardized. So they don't have to reinvent the wheel, they just replicate. So I think we have to decide where you want to be. What is it that you want to do? So this is one framework that can be used, and perhaps you would like to read this paper, but I think you have to pay for it, but at least you can read the executive summary. But it gives you a very high level. Actually, what is it that you want? That is what architecture is all about. What is it that you want to achieve? What is it that you want to share? And what is it you want to integrate? And in life, I think you must move away saying that you have to integrate everything and standardize everything. And that's where things don't work. So maybe we go to a minimalist kind of, minimalist kind of thing, like mentioned by Manisha just now. But at the end of the day, putting person and the patient in the center and what is it that they need. So with that, thank you very much. It has been a very good workshop.